Dr. Paul Jeffords, an orthopedic spine surgeon at Resurgens Spine Center in Atlanta, Georgia. If you are someone who is suffering from back and leg pain from a degenerated disc, spondylolisthesis, or stenosis of the lumbar spine, and you have failed to improve with non-surgical treatment, you may be a candidate for a surgical procedure called an anterior lumbar interbody fusion, or ALIF. Anterior refers to the fact that the surgery is done from the front of the spine, and with this procedure, an incision is made in the lower abdomen to access the spine from this direction. Once the spine is accessed, the degenerated disc is entirely removed, eliminating the source of back and leg pain. The disc space that is left is then stabilized with a bone graft or fusion cage and possibly a titanium plate. What I would like to do in this video is describe the surgical procedure, talk about what steps you will take in preparing for the surgery, what will happen during the operation, and what you can expect in your recovery. After you've been evaluated by your surgeon and it's been determined that you are in fact a surgical candidate, you will probably want to discuss the next steps with your family and possibly pursue a second opinion. Once you have made the decision to proceed with the surgery, the first thing you will want to do is schedule a date for your preoperative consultation. It is during this session that you will have the chance to meet with your surgeon and staff, ask any questions you may have, and sign the consent form for surgery. At this time, you will be prescribed any medications for postoperative care and may undergo additional preoperative tests. This may include a chest x-ray, EKG, and blood work. You will check into the hospital or surgery center the morning of your surgery. Your anesthesiologist will bring you into the operating room and put you to sleep for the operation. There are usually 2 nurses in the OR and a surgical assistant helping your surgeon with the procedure. Once you have been positioned on the operating room table, face up, an incision will be made in the lower abdomen. For a single level fusion, the incision is typically 3 to 4 inches in length. In many cases, your spine surgeon may use a general surgeon or vascular surgeon to help with the portion of the surgery that involves going through the abdomen and the exposure of the spine. The abdominal muscle tissue does not have to be cut, but is moved to the side. The abdominal contents are also moved to the side, and retractors are placed to provide visualization of the disc for the surgeon during the procedure. Once the disc is fully exposed and the retractors are in position, the general or vascular surgeon's job is mostly done, and the remainder of the procedure will be performed by your spine surgeon. At this point, the anterior discectomy is performed. Surgical instruments are used to remove the disc completely. Any disc material or bone spurs pressing on the nerves in the spinal canal will also be removed. Once the discectomy is completed, your surgeon will perform the fusion. A piece of bone graft or a fusion cage filled with bone graft material is placed into the disc space, restoring the height of the disc space and providing stability as it fuses. A titanium plate with screws that lock into the bones above and below the disc may also be used to provide additional stability. At the completion of the procedure, the retractors are removed and the muscle wall in front of the abdomen is repaired with suture. The skin incision is closed with resorbable stitches that are placed beneath the skin. A typical ALIF procedure can take anywhere from 1 to 3 hours. Immediately after surgery, you will be taken to the recovery room for 1 to 2 hours while the anesthesia wears off and your vital signs are checked. Afterwards, you will be taken to your room where you can visit with your family. Your surgeon will speak to your family while you're in recovery and give them an update on your procedure and condition. The nurses will get you out of bed to walk either the same day of surgery or the following morning. Most patients are able to go home the morning after surgery or the following day. Occasionally, some patients will stay an extra day. You should be able to slowly climb stairs before going home, and you may ride in a car or an airplane upon your release from the hospital. You will be given pain medication and a muscle relaxant to help control postoperative pain and spasms. Please ensure that you do not drive or operate any heavy machinery while on this medication. Approximately 2 weeks after your surgery, you'll have a postoperative visit with your surgeon, and your wound will be checked. You may return to sedentary office or desk work 2 to 4 weeks after your procedure. If your job demands that you are involved in heavy lifting or frequent bending or climbing, you should wait 6 months before returning to this type of activity. You can return to moderate duty in 3 months. Typically, your surgeon will see you again to check on your recovery process 6 weeks after the surgery, and then again at 3 and 6 months. When you return for your postoperative visits, an X-ray will be taken to check on your fusion. Complete fusion is usually seen to be solid at 3 to 6 months. You may resume sporting activities such as golf or tennis 6 months after your surgery, provided that the fusion is solid. As with any surgical procedure, there are inherent risks. There are 3 categories of risks arising from the procedure. There are risks associated with anesthesia, risk of complications that can happen during the operation, and risk of complications that can occur after the surgery is completed. Risks of anesthesia are rare in healthy patients, but may include the possibility of allergic reactions to medications, seizures, heart attack, stroke, or death. Risk of complications during the operation include risk of injury to structures within the abdomen, including the major blood vessels that carry blood to and from the heart. Other structures in the abdomen that are at risk include the intestines and the ureters, which are tubes that carry urine from the kidneys to the bladder. Also at risk during the operation are the nerves within the spinal canal and the nerve sac that holds the spinal fluid. Injury to these structures is rare. Finally, after the operation, there are complications that can occur. There is about a 1% risk of infection. Complications from the abdominal approach may include a slow return of bowel function called an ileus, or the rare possibility of a hernia from a tear in the muscle wall. In male patients, there is about a 1% risk of a syndrome after surgery called retrograde ejaculation. You should talk to your surgeon about these risks. Fortunately, for most patients, the risk of these complications is low. Another risk after the surgery is the bone fusion not healing, which can lead to recurrent pain and possibly the need for further surgery. Even if the fusion heals perfectly, a small percentage of patients may continue to experience back or leg pain. Surgical intervention is always the last resort, but when all other treatments have failed, the ALIF procedure can often provide significant relief of back and leg pain caused by stenosis, arthritis, and spinal instability. Unlike posterior approaches, which are done from the back of the spine, the anterior approach avoids damaging the lower back muscles. Going from the front of the spine also allows for the placement of a larger fusion device and may allow for better correction of spinal deformity. Thank you for taking the time to watch this video. You may have additional questions, and if so, you may want to consult with your surgeon.